Okay. All right, everybody, we are started.
We are live.
All right. Well, John, you want to go ahead and take it?
Sure. This is kind of number 2 in a series on DPC, and the first thing I thought I'd do is do a brief regulatory update for the uninitiated amongst us. Direct primary care has had the propensity to be viewed by state insurance commissioners as an insurance product, which it is not. But what that has done is actually necessitated legislation to be put into play on a state-by-state basis that basically says direct primary care is not an insurance product and therefore does not fall under the purview of the State Insurance Commission. And there are 25 states that currently have legislation in place. There was a 26th that was making a run at being number 26, and that's the state of Wisconsin. And the latest information I have from that process was that bill died in the Senate, didn't come out of the Senate. And as I was saying earlier, I think that part of that probably is that they had tacked on a provision to that bill that would have established a Medicaid pilot program for direct primary care, which Michigan and Tennessee both have one in some formation. That's not to say that's not a great idea, because it is, but I'm sure there are political winds that are blowing around that concept. If it had been a clean DPC bill, I imagine it would have made it out of the Senate. And again, that may not be 100% correct, but that's what everything I see is showing. So with that, I'd like to move on really to another area, and that is technology and DPC technology that's currently out there, technology that we're talking about bringing in. And I'd certainly appreciate Brennan and Megan and everyone else's input on this technology piece. But currently, the technology platforms revolve around a DPC-specific EMR, electronic medical record, where they're in play. There are probably a handful of those. Josh Umber's Atlas MD is one of the predominant ones, but there are also a couple of companies that are basically membership management platforms. One is Hint Health, based out in San Francisco. The other is a company called Twin Oaks Software. They're based in Connecticut. And these are companies that basically manage the membership reimbursement. Since these are monthly fees, they handle all the membership management and communication. So they do email blasts to the membership, et cetera, et cetera. All of which we're talking about doing away with to a large degree with the blockchain technology, smart contracts, et cetera. So I'd like to open that up. I know that we've talked about looking at our own, for Citizen Health, about looking at our own EMR potentially, that would certainly make sense to go along with the blockchain and smart contract technology. So, Brendan, do you have anything you'd like to add to that line of thought?
Yeah, definitely. I know with these physicians not billing insurance, not accepting insurance, it really removes a lot of the complexity from their software that they use.
Correct.
The majority of these EMRs out there, they're built around billing codes, making sure you can bill correctly and bill for a max revenue. Well, now if you're really not focused on that, you can have kind of this consumer-based or consumer-facing software that is more like a consumer relationship management tool that is really streamlined. And Atlas MD is a really good example. That's a good piece of software, and I've demoed it. It's been probably 3 years now. I haven't seen it since then. I don't know if, I've watched videos. I get Josh's emails, newsletters and stuff. So it doesn't look like it's been updated too much, but at the same time, it still looks good. And there's a lot of add-ons that you can add. And John, you mentioned that. And I did some research on some other ones. And you kind of go on down the list here. Elation Health. I like what they have. It looks, I don't know if anybody's ever heard of that, but they look like making a good run for direct primary care and being that type of a management tool. But regardless, there's a lot of software companies out there that are trying to make something for this movement. But at the same time, this movement it's very small right now. Let's just say it's 4,000 doctors. I mean, that's 1% of all the primary care doctors out there. So we have a long ways to go just to get this movement going and spreading. So the software is, the potential to have a good piece of software that scales with this movement is tremendous. And I was talking to Ben earlier about this, and that's something that he's been thinking about. Is we've been talking about direct primary care and the growth of it, and he's like, well, at the same time, we're at the very beginning of this. Kind of echoed that point. So, we're at the very early innings of this ball game. We got a long ways to go with just the growth of not only direct primary care, but just the direct care in general, just a subscription model to health and wellness. And we talked about finding specialists and start going with the subscriptions to a specialist, whether it's a cardiologist, kind of just going down the list, whatever types of specialists patients may need. And that type of software needs to be a little bit different. I'm going to start looking more of a shared database. If we look at what the blockchain is, essentially that's a database that's shared amongst the industry. Everybody has the same records, everything's updated. Well, if you have a shared medical database of all patient records and all just health data from everything, everything could go a whole lot more smoothly when people move from state to state, when people do travel, finding other doctors. And Nabil, you might have definitely want to get your take on this, but what we're doing now, we're building an app called Humantive, and we have the ability to import health data from trackers, from various just wellness devices, and also from EHRs, data from EHRs. And what we're essentially doing, which we didn't really set out to do this, but we are building a personal health record that you own. And that's like half of what this new EMR 2.0, whatever we want to call it, which I think we need to drop the E part. It's just
right.
We understand that. Whatever that, clinical relationship tool we want to call it, but we're building the consumer side, the patient side, the person side. So it seems like we need to either build the physician side or maybe partner up with somebody that can kind of come together with us. I'm all for building it. That's kind of the plan anyways. But Nabil, I was going to ask you, with your talks with Human API, what exactly can we get from EHRs?
Well, I'm not sure exactly, but it seems like anything that a patient has.
Yeah.
So that can be imagery, data, visitation, logs, everything, what the doctor, any notes by the doctor. So it's, and what I like to kind of keep going on what you're saying about the app, what I like about it is that it does not only connect to all this clinical, databases, but it also adds all wearables services like 23andMe. And so anything that you have, any data about your health can be pulled and put there on the blockchain. So it belongs to you, not even to the doctor. And that's how maybe we can bank on that and then maybe share it with the physicians so that they can take advantage of it.
Yeah, I love this idea of what we're doing. And it's like, once again, I don't think we necessarily set out to do this, but what we've created is a unified health record of a person from the beginning of their medical record history, if it is on these particular EMRs. And now you have the most complete view of your health. I mean, you have your records from the hospital. You have your genetics with 23andMe. It's 30 seconds. You can import all your genetic data. Microbiomic, I know Ubiome's coming on board with this, and Viome's also opening up their API. And I mean, fitness trackers like Fitbit, Apple Watch, your blood pressure, wireless scales, all this stuff can be imported into your health profile, where it creates a holistic view of you, at this point in time, and also a record of kind of the progression of your health and how it changes based on certain factors. And that's powerful right there, because up until now, there's nothing like that that's existed. And, having the ability to own that data, now you own this data, and that opens up all kind of possibilities in terms of you go to a doctor, you can have it permissioned where that doctor just requests access. You say, yes, I'll give you this, or I'll give you, this 5-year block of data, or whatever that may look like. But it gives power back to the patients and the physicians, because now you go to the hospital and they're kind of holding your data hostage in a way. They think it's theirs.
We charge you for it.
Yeah.
Charge you to copy it.
Yeah.
And I think we talked about this maybe on a previous Health Talk. They profit off of it. They actually
They do. You've hit a sore point. I'm gonna pipe up.
Yeah, that was you that talked about that. Yeah.
Yes. Hi, everybody. I had to slide in late today, but I'm glad I was able to join the discussion. But yes, so not only are they billing to give you a paper copy of your records and a possible CD-ROM of your images, they're de-identifying the data, your health information data, and selling it for quote-unquote research purposes or commercial purposes.
Right.
Most patients don't know that this is happening. So while patients are waiting sometimes weeks for particular pieces of their health record, I have seen references where and in discussions with people where it could be sold and turned around the same day electronically, where patients have to wait for a paper copy.
It's absolutely true. And by most, it's probably 90% of people don't realize that's happening.
And here's something else that's concerning. So while a lot of people want to donate their records and their data to try to advance science, and that's of course essential to moving science forward and big data analysis, many patients just don't know about this process, and they'll agree to donating their information, or not even donating. Their information is being funneled into this black hole. There's no way of opting out. There's no choice there, and they don't realize that this is happening. And I think there is an education and awareness component that needs to happen there.
Agreed.
Yeah. I was listening to a audiobook the other day, and they were talking about this one company that they have all kind of deals with all your pharmacies, all your big public pharmacies, and also with insurance companies. And they take all the data from these pharmacies on us when we go and get medications prescribed, which of course they have the order coming in from the doctor, and they have the insurance claims data on you as a person. So they compile all this stuff, and they sell this demographic report to Facebook. And it's actually incorporating Facebook in this talk. So basically you have all these people advertising to us based on our health data. And that just seems so wrong to me. Like, stop marketing drugs to me. I don't need them. Just because, I fit this profile, it doesn't mean that you have the right to use my data and market something to me that, could potentially harm me. And people don't know that's happening. I didn't know, I knew it was happening, but kind of when this person was talking about it, it made it sound a whole lot worse when you actually know all the details.
To add on to that, all the commercials and advertising you see on TV for medications are typically the real high dollar medications. And there's always a disclaimer. Don't take this if you're allergic to it. And the question is, how do I know if I'm allergic to it if I've never taken it before? So I have to get a prescription filled and then find out I'm allergic after spending $1,400. Is there a money back guarantee? I just think it's ridiculous.
That's why 100,000 people die each year from medication errors.
That's right.
100,000. It's a whole city. That's the city that I'm in right now is dead once a year.
Yeah.
And, with genetics, I'm always harping on this, but 10 years ago, this is 2001, a little bit longer, 10 years. I've been saying 10 years for the past 4 or 5 years, but, when they started, it was $100 million to sequence one genome. And now I got some quotes the other day, $400 to sequence one genome, 100 million to 400. In the next 5 years, it'll be 10 to 20 bucks to sequence a genome. And that point is pretty much free, relatively speaking. So every baby that is born will have their genome fully sequenced, not just a genotype, but fully sequenced. And, with the stuff that we're learning now, with all the data sets we have, with AI, machine learning, really crunching these data and learning more about our genomes, we're starting to learn more with the pharmacogenomic aspect of what drugs work with our body chemistry and what drugs don't work and what drugs could kill us. And if you look at that 100,000 number, well, now it's feasible. It's financially feasible to sequence our genomes, and we can have that record, have that data that doctors use to prescribe medications to us. So it's not this shotgun approach where, hey, you know, all I know of is this drug, so I'm going to prescribe this drug to you. Come back in 30 days to see if it works. You know, it might not. You might die. I don't know. And that's kind of the way doctors write prescriptions now. But in the future, you now can look at your health graph, your health score, and say, okay, this is your statistics on your genome that says these drugs in this class are known to not even work on your body. It's just not going to respond to it at all. These drugs from this class are going to have adverse reactions with your body chemistry. And these drugs with the other drugs you're taking are going to have adverse reactions and kill you. So do not prescribe this drug. And you see that the power of this data is going to save lives. And you know, it just wasn't possible in the past, but now it is possible. And we're starting to put all this together in this health record, patient's health record that you can use in conjunction with a physician. And that's our plan, is to compile all this data and work in conjunction with the physicians kind of on this shared blockchain database where we can utilize the data that we have and learn how to not make the errors that we're making now and in the past. And I mean, I mentioned 100,000 people die of medication errors. Well, on the low end, it's estimated that 250,000 people die of general medical errors. And that could be, I mean, just a long list of things. But that 100,000 number is in there. And y'all, that's a big number to me. You got the World Trade Center, or, you know, anytime some terrorist event happens, it's terrible. You have a couple thousand people die, absolutely horrible. But we're letting this happen every single year. 250,000 people die when we have the technology, we have the resources to stop all this, but we're just not utilizing it effectively because of status quo, regulations, EMRs, just all this stuff that's kind of weighing the system down. So I'm kind of going on my rant here, but we have the technology to fix this, and that's what we're building. And when we're talking about technology with direct primary care, that's what we're building is a platform for patients and physicians and the caregivers and the other healthcare providers to come together on a shared piece of software that we can all interact with moving forward into the future. And I'll have a record of it too, because, you know, one doctor comes on board, he doesn't know what the last doctor did. Well, that's got to stop. And there's other companies that are doing this. HealthLoop is a good one. They're kind of have this patient care loop, going from doctor to doctor, tracking everything. And I love what they're doing. So there's a lot of good ideas out there. But putting all this together with this emerging blockchain technology and this emerging growth and movement of direct care, it's a perfect match.
I think there's a couple of things that, you know, in that particular vein, if you will, pardon the pun, that are important. And I think I've mentioned, I think you all know this, some of you do, that I'm an adopted guy. I don't know my birth parents. I don't know my medical history. I know that I've been hospitalized a couple of times, and I know where I was hospitalized. I have no longitudinal record whatsoever. I was like most every other kid, saw a pediatrician when I was little. By the way, in respecting direct primary care, that was paid cash. That wasn't an insurance visit. We insure everything today. The other thing is that, so I think from that standpoint, having that information, especially in my case and other people that are adopted's case, you would have a better idea of what medications would be effective, having that genome mapped out. I think, again, too, the concept of technology with direct primary care, as you were alluding to earlier, Brennan, about this scalability where direct primary care physicians have available to them all over the country. Let's say, for instance, you were going to San Francisco and you needed to see a direct primary care doctor rather than pick up the phone and call your Hattiesburg doctor, then that would also facilitate being able to see a DPC doc who has the same mindset that your doc does wherever you are in the country. So that's another very valuable piece of the technology puzzle. But I think, again, to have that kind of information at your fingertips is literally vitally important.
Yeah.
John, I'm so glad that you brought that up because from a patient and care partner's perspective, if you think about the next generation or people's children, tragedies happen, accidents happen, people don't wake up the next morning, and sometimes the younger generation has no clue. They don't know what the medical history was. They don't know who the doctors were. So to have a comprehensive longitudinal record is really something that could be passed down to almost as as part of a living will to the next generation, and that gives a wealth of information on what your risks are and what parameters may be impacting your health. Take, for example, we take a family history when we go to the doctor, and I'll try to recall what my grandmother might have had or what my aunt had, but is that something that's genetic, or is it impacted by the type of lifestyle they led, or the zip code, or the region of the world that they grew up in?
Right.
Just, that's something that's important. Just because somebody had a stroke or has cardiovascular disease, am I a direct target because my grandmother had it? There's much more to that conversation, and having this kind of a record, to your point, could be a wealth of information that we're not leveraging right now.
Well, I mean, it's, is it external factors, like you said, location, environment, et cetera? I know I'm a 23andMe aficionado because what that did was gave me at least some idea of what my genetic makeup is, what I'm potentially, may succumb to, what kind of, markers I may have in the research they did on me. It'll give me at least some idea of what I'm susceptible to. So that's leaps and bounds ahead of where I was 3 years ago. I had no clue. And that has impacted, my ability to at least be wary of those things, adjust diet, lifestyle, exercise, et cetera, et cetera. So there's a lot of value just in that. And yes, I realize that 23andMe is selling my data. I've given them permission to, as long as they de-identify it, which I have no idea if they do or don't, in the interest of, furthering medical science. But I know that in some cases I think it's been published lately that they're probably making a good bit of money doing that with my data and everybody else's. Well, they're in business for some reason besides satisfying the world need. But at any rate, I see a lot of value in that, and I'd be hard pressed because what it would mean for me today is to get my medical history, or at least hospitalization history. I'd have to call each hospital that I was a patient at, probably every doctor, urgent care, et cetera, and try to wheedle information out of them at my cost. It would be a painful thing to do. So I'm looking forward to when getting genome down to $20, I'll do it.
Right.
It's
Wouldn't that be the best place to discover, your genomic history? If a DPC doctor could just, run it, and then you come back to your doctor, and then you have the results.
Right.
A lot of people discover this stuff on their own. They have questions. You could have stuff that shows up and you have no idea what you might be susceptible to. So at least you would have that trusted physician there to help make a good game plan for you. That's where we got to go with this. So it's not like you get this in the mail and like, what is all this? So patient education is crucial, and then you can go through it with your trusted physician to make a really good proactive plan.
And I again think exactly what Grace said really makes a lot of sense. I mean, I've got kids. I now have a grandson. That kind of information is important to them as well as to me and my wife. And, it's the kind of thing that information should be handed down. I'm, encouraging my son and his wife and my daughter to do the 23andMe. I mean, okay, we know mom and dad are still alive, but, what else is, potential? Give it thought, do that.
Yeah, because, you sitting there and later on down the road, you might have a serious condition that you can't point and figure out the actual root cause of it. Well, if you look at your genetics, you could start at least narrowing the options down to say, okay, well, you have the variant for this particular disease, so let's look at that a little more. And that is big, is getting down to the root cause of your symptoms. A lot of times you have symptoms, but it might be from something else other than what that doctor was thinking. So having just more data to kind of peel back the curtain to really understand what your body is doing, what is it saying, and exactly why you're having these problems in the first place. That's big. And just data in general, having this data become more readily available and having the computing power to sift through this data is huge going forward. And Megan, I'm going to echo your point a little bit. Not only do we have the ability to sequence a genome. Okay, have you ever seen the results from that? It's hard to understand. And the big opportunity is interpreting that. Is figuring out, okay, what does this mean? Because this variant might interact with this over here, and this variant might interact with your zip code, like Grace said, or your lifestyle habits, or drinking coffee, or whatever that may be. So the interpretation side of it is going to be huge, and that's where talent comes in. It's going to take a human intelligence to sift through a lot of this, and also AI, machine learning to really just take a crack at all these huge data sets that we're compiling now. And you take it a step further, if we do have this shared health record now, if you look at Humantiv and say we get 1 million, 2 million people who start kind of growing this out, well, we have a huge shared database of health, the most unified record of individuals' health ever. I know right now there's a campaign, I think it's called All of Us. I think it's allofus.org. It's a campaign that I think just launched, and they're trying to sequence 1 million people, their genomes. And I'm thinking, well, hang on, other people are doing that. Like 23andMe has already done that. It's kind of redundant. You're doing the same thing. But at the same time, you look at a lot of these data sets, and it's heavily skewed towards white males. Looking at all your data, and it's like, well, we're making predictions based on white males from America that were born in America. It's just, you look at the world, and we have so many different backgrounds, so many different types of people that we've got to spread this out. We have to get data from everybody before we can actually make an accurate diagnosis. Because if you're feeding all this data to an AI, well, it's only as good as the data it has. And if we don't have data that represents the whole, it's not going to be as accurate as it can be. So I think that's a big thing, is a push for what's the word I'm looking for? I don't really know what I'm looking for there, but what I mean is just trying to target everybody and get from various backgrounds to be on board with this. Because if you really think about it, we're all one species living on this ball of mass floating around the sun. Like, we're all in this game together, and it's kind of time to come together and put our data together and use our intelligence to solve and cure these diseases that are killing us. Because we're having more and more chronic diseases. People are just kind of going downhill if you look at species in general. And the future doesn't look very bright if we continue going down the way we're going now. And a lot of that is from just nutrition and personal behaviors and stuff out there like that. But broadening it up, if we do create this almost like a global movement that connects countries together for one shared purpose, one shared goal, and that's really to compile one huge data set of all humans. That would be amazing to have an initiative for that. That's something that I think countries could and should get behind, because it's going to benefit them. It's going to benefit their neighbors. It's going to benefit everybody to have this huge combined data set. It's just kind of an idea that I've been floating around thinking about. That could grow legs.
Well, disease doesn't just affect Americans, white males. It affects people all around the world. So what we have with the data set you're referring to is not representative of even the United States, or even potentially a state, much less another country. Mm-hmm. And yes, we know there are certain diseases that are more prevalent in certain countries, but as you said, without that kind of representation, it's going to be, one of our goals, one of our stated goals at Citizen Health is to get rid of disease, basically by 2050. You're not going to be able to do that without data, and you're not going to be able to do it. And I don't think we were specific to disease in Mississippi or Alabama or Arizona or we were specific to disease around the world. So
Yeah.
what we've got now isn't going to get it.
And we're in a perfect time for this to happen, because you look at all the exponential technologies that are about to really start going straight up. I mean, there's technologies out there now with microfluidic technologies and stuff that you can literally just spit in a device and plug it up to a USB drive, and it can determine whether you have a set of the range of diseases. And that's already happening now in Africa. You know, you go places that have no healthcare infrastructure, and you can determine whether this whole tribe or this whole community village, what diseases they have. I mean, that's huge, just figuring out what disease you have, and then you can treat it accordingly. I mean, this stuff is happening. And you're talking about a genome sequence at the doctor's office. That's not far off, where you can literally just spit in a tube, hook it up to the computer, and in 10 minutes, you're going to have it. You're going to have your genome sequenced. And I mean, there's a wide range of possibilities for this. And it's exciting time to be a part of, for sure.
I wonder what that CPT code will be. Never mind. We're not worried about that.
Yeah, and that's what was that quote I was trying to remember? Michael or Clayton Christensen. I keep mentioning him. He's got a very good book. It's an audio book, so I never see the title of it. Hang on a second. I've got to tell you all this. The Innovator's Prescription. Like, I highly recommend this book. I'm halfway through it, and I love it. I mean, I dig into healthcare a lot and just think about disruptive ways to fix it. And this guy here, I mean, he kind of just makes me think a lot. So that says a lot. I highly recommend that book, by the way. That's what it looks like.
What's the Innovator's Prescription?
Yeah. And it's excellent. It's talking about really everything in healthcare and how it could be better and how we could disrupt it. And I'm just like, yeah, that's what we're doing. That's what we're doing. So he's got some good ideas. And he was talking about, basically to sum it all up, and our whole healthcare industry, our whole medical industry, the incentives are aligned for the treatment of sickness. Versus his theory or his thesis is that we should all move to a proactive model that incentivizes our whole industry to focus on health. And when you change those incentives and you align everybody to focus on those incentives, that's when the disruption starts happening. That's when people stop going for that profit motive, for that fee for service model, and start going with, let's just keep you well. We can profit off you being well, or we can profit off you being sick. I'd much rather profit off somebody being well. And I'm not against profit. I mean, you can definitely change up the business model and the strategies to focus on the health and wellness aspect of it, and be proactive about somebody's health and make a decent profit. So that's I'm going to sum his whole book up. That's kind of his focus. It's really good. Still recommend it.
I mean, what you're talking about there is flipping the model right now, because all the money, 70% of the model money or more, is going to the sick care.
Yeah.
We're talking about flipping a lot of money, more coming out of sick care, going to well care, if you will, or health care. And that's viewed with a slanted eye by some folks.
Yep.
It's threatening their bailiwick.
That's what Dave Chase says. He said there's about to be $1 trillion shift.
Yep.
Going from old players to the new players. And that's us. That's what we're doing. I think there's a CPT code for cutting somebody's leg off for, diabetes, for anything, just cutting your leg off. There's not a CPT code for following up with a patient and teaching them the right way to eat.
Right. There's not a wellness CPT grouping at all.
That boggles my mind.
So I wanted to bring up something really cool that I saw last week. So I was in Chicago at the Barrel Institute's Patient Experience Conference, and it was over 1,000 people, I think, that are all dedicated to improving the patient experience together, and people from across the nation. So one of the talks that I attended, it was about the improvement of the patient experience by using virtual avatar-like advocates. So when we talk about the technology of DPC, how can we enhance that and give people options for engagement? So you have that face-to-face time or consult, but as you all know, after that, that's when the questions arise, that's when there's confusion, and who do you call? And it's also well known that people like engaging with chatbots and can ask maybe more sensitive or quote unquote embarrassing or delicate questions with some kind of a technology or a chat box versus, facing someone and asking them. So this company called Telehealth Services wants to leverage or create a virtual nurse essentially to be an advocate. And they use big data, and it can be diagnosis-based coaching. It could be simple interactions to say, what is this medication for? When am I supposed to take it? So it could be as simple or as complex. And they are being implemented. They're using these services, I think, in a hospital in Illinois, and they're seeing tremendous results. So I just wanted to think about how we're thinking about the technology, what enhancements or what things could be in place off the get-go to not only differentiate us, but really to strengthen the model. I'm all about DPC, but here's something else that can also support patients outside of that consult or outside of that DPC interaction.
Yeah, I'll definitely shed some light on that. Have you ever used Intercom? You probably have on the consumer side, or the user side, where you see that little chat.
Yeah.
Right corner. Well, on the back end of it, it's really neat. It's a way to manage all the tech support, or if you have an app, just all the users, and it's a continuous communication feed. So you can go in there and have a conversation with somebody for all day, helping them with something, and then the next person from that shift comes in, and they can see a history of all the communication. Now, everything that's happened, they can just pick right back up. And I did this in my previous company. We had there's like 2,500 users that always needed help with something, and it was seamless. You could step in there and you could pick it up on your phone, start texting them back or messaging them back, pick it up on your computer, and just start chatting with them there. It had connections with our phone service. It would show that you log calls. And it was just this ongoing dialogue with this user, which could be the patient. You have this ongoing dialogue with the patient and the physician. And like you said, Grace, a lot of times you're in the doctor's office. You might not. A lot of times you just forget to ask questions. I do it all the time. If I'm there, I'm not all the time. I don't go to the doctor much, but it's like, man, I wish I'd asked him this. Well, now with this new direct care model, well, yeah, just pick up your phone, just text them. Or call them up, or just have that messaging service with them. To take it a step further, this is our plan, is to have, we're building this health intelligence for physicians, and that's kind of the idea, is to start, have an AI in the office, and almost like a digital nurse sitting there, just like Alexa sitting there. I know other companies are looking at this, but why can't you have a digital nurse, like a digital nurse that sits there and talks to you and gives you updates and can schedule appointments for you, and also can take the place of a nurse. You can have these smart clinics where a patient walks in there, they check in on their phone, they go sit down at this sophisticated chair, they stick their arm in a blood pressure cuff, it weighs them as they sit there. It takes the place of a person. And, that AI, that health intelligence there, can look at all your previous health history, the trends on your Fitbit, your sleeping habits, your medication, and say, okay, and have all this data kind of just casted up on a screen for that physician when he does come in there. And now you and the physician can sit there and talk face to face, and have this digital nurse sitting there and just recording everything, dictating everything. Every time something relevant is spoken, it kind of casts up there and says, okay, this is a demographic report on the state of health on your age range right now, and just whatever that may look like. But having that intelligence helping doctors out, supporting them on their decision, and really just offering up suggestions on latest PubMed articles that were released, or anything that can augment that physician's intelligence. And taking it a step further, this physician can train this health intelligence as their own nurse, where it's not like Alexa, where it's kind of uniform all across the world.
Scripted, yeah.
But more of, okay, like as a doctor, this is my protocol. This is what I like to do for this situation. This is, the steps I like to go for this therapy. This is the way I like to handle these patients. Well, this health bot can start understanding this and work with that physician kind of in his workflow, his or her workflow. And then likewise, when that physician's asleep, well, then you have a chat bot. then that health intelligence turns into a chatbot.
Correct, because they did have some information and statistics, and I think the case study was postpartum, and they had different videos and chat options, and they recorded when there was engagement, and it was across the board 24 hours, so it wasn't during business hours, because questions don't arise only during business hours. And they had a large uptick of moms that were looking at things at night. Perhaps they were up with the baby, they were rocking the baby, nursing the baby, and in their hand they have their phone. And at the end, they had surveys. I don't want to call it a formal satisfaction survey, but some of the key takeaways were that people who use this virtual advocate felt cared for, felt listened to, and that we're talking about a simple electronic platform, and that was giving them this feeling of comfort, support, being cared for, and empathy, which was what resonated with me, that we're not achieving that in face-to-face interactions right now. So there's an opportunity there, and it gives people that flexibility that at their fingertips, when they need support, there's a lifeline or a support system.
Oh yeah, having somebody to talk to is huge, because having just this frustration that, it's 11 p.m. I know my doctor's not going to answer. I can't get in touch with anybody. And you just kind of have that fear going throughout the night. Do I need to go to the ER? And a lot of people do go to the ER. That's why we spend so much. But having that just a simple digital nurse where you can sit there and just text. And these things are good. I play around with chatbots all the time. They're getting better. And it was a big fad here 2 years ago, but I think they kind of overestimated the short-term effect, but underestimated the long-term effect. Chatbots will be prevalent for sure in everything we do, and they're handy. You don't need a call center staff, and you can have just one program running.
So I wonder if actually those assistants will help in cases of, and actually I'm asking John, there's all this movement of medically skeptic people, vaccines, etc. And those, it doesn't matter how an advice comes. If it comes from a medical professional, they will not take it. Would another source of information, for example, assistants or something like that, artificial intelligence, help in that case?
I think that in some cases, yeah, there are some people that are way more skeptical than others, but then you've got the fringe, if you will, like the Dr. Merkola's and Dr. Oz to some degree. They're on the fringe on the other end of things. They're against everything. We have this running battle in our house about vaccines and autism and all the media stuff. I think when you remove all that buzz, you've got like a second opinion, so to speak. I think they would have some value. I do.
Because I can see patients, for example, just wondering what to do, and they have Dr. Mercola, website, and their doctor, and they don't want to go to either. Is there another place where they can become, just trust another source? And if it's not a human, maybe people would trust it more.
I tend to agree with you. I think that one of the things behind the DPC movement is though, to develop that trust and to develop that over time in longer visits with your doctor, as opposed to the 7-minute wham, bam, thank you, ma'am visit that we see today in primary care. At the same point, if you don't have that trust, you just have that little bit of doubt, it would be good to have another resource that's not 180 like Mercola or whomever. I find value in pretty much looking at most things, but I think there would be value in having that third option.
Sometimes you go for a doctor visit and you forget to ask your question that you had for the doctor, in that 7-minute period that you get, window that you get.
Perhaps even to back it up, even with some data, like if you say 86% of the time patients do X, Y, Z, or so even to show that this is where the majority of people, when somebody has these types of symptoms, let's just say, 49% of people call a nurse, 12% of people decide that they're going to go to the ER. So I think if we back it up with numbers, I think that would help people make a better decision if they did have to do something or if they needed more professional care or an opinion. So maybe just even showing that. So here's your question. We're narrowing things down, and then here's the data to back that up.
I think that's a good point. I mean, a lot of people, most everybody will look at, something that has a predominance of data that points in one direction, and at least give that consideration. If they don't have it, it's a crapshoot.
Because there's a huge thing too with medical direction, and then actually practicing being a doctor. There's a line. So you can only do so much. Like, you can't diagnose unless you are a physician. So a physician can help you, but they might need even more information. So it's just making sure that we're doing the right things as we're helping these patients get the care that they need.
Yeah, I'm gonna.
Megan, you
Go ahead, Grace.
bring up a really good point, because think about how many times personally you might have a friend where in the middle of the night they're wondering, what do I do? Is this severe enough to go to the to warrant a visit to the emergency room? And having at least some type of criteria or a reference that's based on data or numbers can sometimes, to your pharmacy, they'll say, in case of an emergency, please dial 911. There are insurers and payers who have publicly stated that if your visit didn't warrant an emergency room emergency, you will be responsible for that bill. So that's making people second guess themselves even more. We're almost asking patients to be able to self-diagnose and triage themselves appropriately, which is absolutely crazy.
Yes. Thank you, Anthem.
Yes. I wasn't going to name names, but it's out there.
I will.
I know those freestanding ERs are coming up, and I think there was something, it's a big, they're the big culprits too, I think.
It certainly doesn't help. It doesn't help when you are not sure. There's not a lot of information in the middle of the night. So if you're like me, you're going to play it on the safe side. But if you wait it out and that turns out to be the wrong decision, we haven't helped anybody, because now too you've just made a situation even more catastrophic. And this isn't helping the healthcare system. It's the wrong deterrent. So let's give everybody the technology and the tools and the help needed to help make better decisions and help get you, the care that you need. Makes sense. But, I think that just understanding, though, too, going back to some of the things that we've just been talking about, though, with just these care lines, that's where some of our original products came from, and they are so underutilized, especially after you've left the emergency room, and especially when you cannot do things, sometimes face to face. Typically, after you've gone to the emergency room, you've had some sort of traumatic event. Some people too, they're not enough to be admitted, but they get sent home. Of course, that turns out maybe sometimes to be the wrong decision. They have to come back and they're wondering. So it's that extra added line. And yeah, mistakes were caught. Readmissions came back down. Making sure that people got to their primary care, it all made a difference when we did these studies. So yeah, we definitely have to place these things into citizen health as well, because they're sorely needed. And I think that's the one big thing: communication between patients and providers. There's hardly any fields of study here. There's hardly any resources. And when people are talking about communication in healthcare, it's typically between provider to provider or care circles. And that's wonderful. Those people do need to talk. Those people do need to communicate about how to coordinate your care. But the majority of time, they're leaving out the patient. And that patient, bring that patient back into the center and place them into the communication circle and into the communication with the care team. That is what is missing from healthcare. And that's my biggest platform about what needs to happen and how we can fix it.
I love that point, and I want to kind of talk about a different angle of that too. Like, for instance, like my dad, he had some issues a while back with his prostate, and it's like, Well, this might not be a good example, but it's kind of a general concept. Is, you know, you have a friend or family member that they have a condition, and they tell you the problems, but from what you see and from their change of habits and kind of the reactions to things, you have a different perception of how this is affecting them versus how they feel that they're affected, if that makes any sense. And, you know, having that caregiver in the communication, the line of communication with the provider, you know, the patient might just tell the provider, yeah, I'm feeling like this, and this, but the caregiver's like, he says that, but in reality, his whole entire life has changed, you know, not eating as much or not as active or whatever that may be. And I've seen that. I mean, I've seen that with my wife, seen that with just various people of, you know, you say your conditions are one thing, but from what I see, it's a little bit different. And that could be helpful. You know, having just the communication in general is helpful for what we're trying to do. And that's one thing I've been thinking a lot about, is having that communication aspect. I think that's one part that we're missing in what we're doing in this app, is having that line of this kind of just a open line of communication with healthcare providers. Having this closed loop of communication ongoing, almost like I like the analogy of having an intercom for healthcare. I really do. I mean, it makes so much sense to me when you use it as on the front end, then use it on the back end. You see how things just progress, and you can keep track of everything. And it's definitely what healthcare needs. And I think that's what we're building. So, and I'm also going to say another thing. You're talking about data, and I think Grace, she's not on, but she mentioned that some people, and almost requires people to self-diagnose. Well, in a way, I self-diagnose all the time. I mean, everybody Googles stuff, right? You know, you get a headache, you have some pain, you're going to Google it. Well, it's been noted that Dr. Google is not the best source of data sometimes. But what if you have your health records, like everything, your genome, your microbiome, your longitudinal health records, and then you're searching based on that. You're not just searching from a random Google user saying, hey, what is the pain in my head? You're actually searching with the context of your condition, like you're searching with your data points. So then you can start linking up articles that are relevant to you and discarding articles, PubMed articles that don't have any bearing on you. So then you can kind of get a customized or personalized results from your search that can help you self-diagnose better. Because I know I've told the story about my wife's friend that basically self-diagnosed herself with Cushing's disease and helped another patient self-diagnose themselves where doctors didn't do it. So there's a huge lot of power that patients have, because I mean, you're living with this every single day. If you have a condition and you can't find a cure or find the cause of this problem, you're going to research every single thing you can, and you're going to become an expert in you. And I think we need to empower people to become experts in themselves. And if they do have a friend or family member with a condition, that, you know, they're empowered to help them and really become an expert in the person they're caring for. And that's where it's at. Because you think about, if you look at a year and you look at the amount of time that you spend with a doctor, I mean, it's a speck in terms of the amount of time you're spending with yourself and with your friends and family. So, you know, empowering the people outside of the doctor's office is really what I think we should be doing too. And then it's all coming together. That's one big part of it. Having that right data, the right context for, you know, learning more about you yourself and helping yourself.
Absolutely makes sense, because then you, the patient, are meeting the doctor in the middle. So the patient comes to the middle, the doctor comes to the middle. And all of a sudden, you know, we've got, you know, both parties that are really working and proactively working together. You know, in the days of Google too, one of my friends, she helps with cardiology surgeries. And she's saying we're getting just the opposite, where people are going to Dr. Google after like treatments and things have already started to, you know, be put in place. And they come and they say, well, why are you doing this? And what if we did X, Y, Z? So they're starting to become even some of a mistrust. And it's like, wait, you have to trust us because, you know, we know what we're doing. So, you know, but if that was more matching to you and that could give you reassurance that the information that you were being matched up to was matching what your doctor was treating you with, then of course we've got more trust in the healthcare system, which of course is something that needs to be reestablished. But yeah, so we're going to opposite ends when again we need to come together more in the middle, you know, for everybody's sake and everybody's care. So it's difficult.
You know, Grace isn't on here. She's talking about a digital avatar, and this is something that I've been thinking about a lot too. And Nabil, we've had conversations of organs on a chip. You know, with Emulate Bio is a company that's experimenting. They have basically microchips and have the ability to mimic an organ, your actual organ, with your cells on a chip about this size. And I can envision that being a stack, almost like a small little desktop sitting there, a stack of you, your digital avatar with all your organs. And you can constantly run tests using, you know, various drugs, experimental drugs. You can constantly run these tests on yourself. So you might have a potential propensity to have this disease later on in life. Well, you can start testing experimental drugs on yourself, your digital avatar now. And you don't have to worry about going through the expensive clinical trials and killing dogs and whatever else they test on. I mean, this kind of is a big paradigm shift for this. And this is some of that technology I was talking about. But that also makes up your digital avatar. You know, this is you. This is your digital body. And I would much rather run computer simulations on my body versus just taking a drug for 60 days and seeing if it works. So just a thought. It's coming.
Most definitely. And of course, too, you know, you have to think of the people, too, that do step up for clinical trials. You know, some of these people, they don't have a lot left to lose. It's one of their methods of last resort. But a lot of these people, too, they end up dying in the process, or they try it out experimentally just to see, and then all of a sudden, too, they end up, paying the ultimate price. That's scary. So to all those people who have stepped up, you know, we owe them our gratitude. You know, but to think that we could even cut down on those people that have had extreme adverse events from clinical trials and the drug testing, that's a big deal. That's a big deal.
Yeah, I think like clinical trials, it's so the whole process. You test on healthy people first. And y'all do know that. Like, you test the drug on healthy people to see if they have an adverse reaction. Like, that's the first group you test on. How idiotic is that? Like, we now can, I mean, that's another talk. But I think the whole clinical trial process it's outdated. And Emulate Bio and these companies, they're gearing up for that. I mean, they have already started partnerships with different pharmaceutical companies just for that. But if you look at 5-10 years down the road, what we can have with the technology we have, yeah, definitely. I mean, you're reducing the cost of these clinical trials by a factor of 10 at least, and the time. I mean, you could run 100 different simulations in 24 hours, which it would take you a year to do. So, I mean, I see a lot of really neat things happening in the future. It all starts with data. That's where it's at. Data. All right, everyone. Well, does anybody else have anything to add? Any questions, comments, concerns? Joe?
I just had a couple of things I was going to address, and we've talked about them, but I think there's a couple of folks on the call that may not have heard them. One was what CMS is taking notice of direct primary care. They've put out a request for comment about a couple of initiatives that they are thinking about. One is doing DPC CMS style. They're calling it direct provider contracting, which just fanned the flames with the traditional DPC community. And the other is they're talking about legislation that's already in play but not enforced, and that is standard pricing for hospitals. They're going to be required to post standard prices, which is tantamount to doing nothing because there are no standard prices. The last, and those are, I won't belabor either one of those, but at least CMS is taking notice of the direct primary care movement. The one other thing that I had that I really wanted to address was expanding this concept of direct care to include specialists. And to illustrate that, I had a very interesting conversation with a doctor today. He's the chief of nephrology for University of New Mexico Health Science Center. So all their hospitals and affiliated clinics. And he questioned me about direct patient care for his non-university affiliated things that he's doing. And he said, I was particularly interested in talking to you about it because I've become aware recently of the extreme gradient between what the university receives for my work and what I receive for my work non-university related. I said, yeah, welcome to the real world, doctor. So we're going to be seeing more and more specialists looking at direct care, whether it's in his situation as an academic or strictly just the community-based specialists. I think that's something we really need to talk about, and I would certainly like to. I will get some input from my DPC friends on their thoughts on that.
I think, yeah, one thing we need to kind of clarify or really organize is what would be the best specialist to bring alongside the primary care physicians. So say we have a group of 5, like primary care is 1. What are the other ones? A cardiologist has to be
Right.
Oncology, maybe that needs to be number 3. I think diabetes, or that I really think that falls under nutrition. Nutrition, diabetes could almost be 4. And 5th and 6th, I don't know. Does anybody have any ideas of what we can kind of include in the core group?
I mean,
Well, I think you've hit on, get an endocrinologist involved from the standpoint. And then I think you're right. Have nutrition experts that cross all those specialties. Because, everything's involved in nutrition, cardiology, diabetes, everything else. But as far as medical specialties, I don't know that neurology would be there. I mean, there's a laundry list of medical specialties. I'd have to put some thought to that, but I think you've hit on the top 4 or 5.
Yeah, you spoke about nutrition, but maybe like a pharmacist, pharmacist.
Yes. I think pharmacist is a great idea. Not a medical specialty, but definitely
Right.
a positive adjunct. And a lot of pharmacists today serve as a lot of people's doctor.
Right.
And to add to that, I think pharmacists should play a bigger role. I think we should bring them in the loop. And they can do a whole lot more than just what they're doing now, which is filling bottles. Robots can do that now. I talked to one pharmacist, like, yeah, robots pretty much do everything now. And we're kind of left just talking to the patient if they have any questions. I mean, pharmacists, they go to school for a long time. They learn a lot. And definitely learn a lot how medications work within the body, and also nutrition. That's kind of a big thing now. What's it called? It's like a bigger trend now, deprescribing, where pharmacists are learning now how to not prescribe medication, how to say, okay, well, do you really need this? Well, let's look at your lifestyle. Are you getting enough sleep? No, maybe you just need to go to sleep earlier. Sleep 7 hours a night versus 4. Lay off the caffeine at 7 p.m. and kind of point over here. But and that trend of looking at the patient as not just a revenue source, but just looking at the patient as a person, trying to optimize their health using the knowledge they have. And that's a trend. You're starting to see more and more people focusing on that. And I think that now that we have the technology to do it, I think more and more people are apt to do it, especially if we can reward them, incentivize people to focus on the health side of it. And that's where it's at. And that's the benefit of blockchain technology and tokenizing the incentive model, is you can align those incentives where it does push everybody to the greater good and not, do the push and pull. Somebody's going to come out on the short end of the stick type of deal.
Okay. That's all I had. Just wanted to get those couple of things thrown out there.
Next time, I think we need to have this DPC talk multiple more times. But I want to add in association health plans next.
Okay, that's a good point. Very good, Pimp. Very good.
There's not a lot out there like that. Nobody's really talking about it. So I think that would be something good to kind of tie in with direct care, that model.
We've had the discussion about health sharing plans, but this is another alternative, which is getting a lot of bad press right now. Because why? Because the health insurance companies don't want it to go anywhere.
Mm-hmm. Yep. So I need to dig into it more, but I like what I've read and heard.
What's it called again? It's Association Health Plans?
Yeah.
I'll look it up.
They're currently available, but they're short term, like 3 month. It's for people that are in between either group employment or exchange or whatever, for whatever reason they're uncovered. And what the association health plans are looking at now are lengthening them to at least a year. I think they're 364 days under current legislation. So that would be a big help.
Mm-hmm.
Big help.
More options are better.
You mentioned exchanges. I just want one more thing, and I'll be done for the night. When I was coming back from California, my Uber driver, telling you, like all the conversations I had, it's probably one of the best conversations I had was with my Uber driver going to the airport. And he said his health insurance premium was $382 a month, December of last year. January 1st, $1,310. 382, 1310. He went on a rant. I asked him, I always ask people, like, what do you think about healthcare? Just open up conversation. And he went on a rant about just everything that's wrong from his point of view. And there was so much emotion behind that. I mean, he couldn't afford stuff for his family, because now he has to pay $3,000 a month for insurance, and it's going down the long list of things. And, that is true for so many millions of Americans that they just can't afford things. They can't buy their kids new soccer cleats or go take their family out for dinner because dang premiums increased 300-400%.
So you hear lots of people say their health insurance premiums are more than their mortgage.
Yeah, seniors have to choose between food and medicine. A lot of seniors are having to make that choice. I mean, they just don't have money.
Yeah,
it's very sad. And the old buzzwords are coverage does not equal care.
That's right.
Just because you have insurance doesn't mean you can access it with a $7,500 deductible.
Right.
I will say, though, that the one common thread was fear. People were scared that if they did go to a model that's away from health insurance, they're scared that if they got in a car wreck, they would not be able to pay it. So that is the number one first question people always ask is, if they do go to this subscription-based model of healthcare, what happens if I get in a car wreck?
It would be catastrophic. Yeah.
That's always the number one question. What happens if this, that, or the other? And, you've got health sharing plans now, association health plans. Those with group insurance that are using direct primary care, they can fall back, on their catastrophic piece. But that's a hell of a good question. I mean, people say, well, if I got in a car wreck, what would I do? And I say, you go to the ER. Well, I can't afford the ER. So they still have to treat you, but you're going to get a big fat bill that you won't be able to pay. I mean, it's a very real fear.
I think the model we're trying to put together is a peer-to-peer model where, like the peer-to-peer loan industry, look at that now, how fast that's growing. Well, it's the healthcare sharing industry. I mean, it's the same concept as you're in this group. And if somebody in this group has that bad car wreck, well, you're contractually obligated by smart contracts that you're going to donate $10 for their calls. And likewise, if you get in a car wreck, you can rest assured that they're going to pay for you. I mean, that is the sharing economy. That's the growth of everything that's happening now with Kickstarter, or GoFundMe, and all these crowdfunding attempts for medical expenses. Is people will donate to help somebody else. That's human nature. People want to help other people. And if you create this environment where it really removes all the intermediaries and you can do that directly with your peers, I mean, that is the model that we're doing. And that's my answer for people. And people don't quite grasp that because, for one, they don't know about healthcare sharing ministries, how it's taken off and how that works. When people don't know, it's hard for them to conceptualize something. So I think that's going to be the biggest part for us, is educating them on how this does happen. And we talked about John putting together these numbers in this plan. Of course, we can talk about that later. But to ease everybody's fears, is go ahead and have everything diagrammed out. Like, if this happens, this is what we do. If this happens, this is what we do.
Right.
So. All right, everyone. Well, thanks for joining us tonight. I appreciate it, and time is valuable. I definitely appreciate everybody's time. And also, while we're on here, we have a crowd sale going on.
Get your email
You got
So,
that? Good. We
yes.
haven't. I sent that out. We haven't put it on social media yet, but we're just kind of opening up for friends and family and acquaintances now. So if you're interested, if you know anybody that's interested, send them that link. We have all the information there. And
I'll do that. Yeah, I'll get the word out. But yeah, thanks.
Great.
Good deal. Thank you. All right, everyone. Well, have a good evening, and talk to you next time.
Thanks, everybody.
See you guys.
Thanks, everybody.
All right.
Bye-bye.
Bye.
The next talk will be May 10th. Same bat time, same bat channel, 7 Eastern, 6 Central. So come back and join us.
Yeah.
Thanks,
Well,
everybody.
Thank you.
we got to come up with some more discussions on that voodoo doll thing that Brendan was talking about, where you have an avatar of yourself.
Yeah.
Oh, I can talk a lot about that. I mean, it's
It's the voodoo doll analogy or whatever.
yeah, I would love to have that conversation, really get in depth with the technology.
Yeah.
That's neat stuff. Okay, everyone. Well,
Thank you.
everybody.
it's time.
Bye-bye.
Good night.
Bye-bye. Good night, guys.
All right. Bye.